Hi, everybody. This is Sabrina speaking. The subject I've chosen to cover for our presentation assignment is female genital cutting and mutilation. So, what is female genital cutting and mutilation? According to one source, female genital mutilation or cutting, also known as FGM/C, is defined as any procedure involving partial or total removal of the external female genitalia or other injury to the female genital organs for non-medical reasons. So here is an image highlighting the different types of female genital mutilation. You can see there are three going from left to right, and these classifications are dependent on the amount of tissue removed and reconfigured. Some reasons given for performing this procedure are that in some cultures, this is considered a rite of passage, a way to preserve chastity, ensure marriageability, improve fertility, promote survival and beauty. By some, it's seen as a religious requirement, and by others, it's seen as a way to enhance sexual pleasure for men. And here is another graphic that's a bit more anatomically correct, once again broken up by the various types. It's important to note that any of these procedures may lead to hemorrhage, shock, acute and/or chronic infections, urine retention, severe pain due to a lack of anesthesia, psychological problems, HIV transmission due to a lack of tool sterilization, childbirth complications, and even death. So, who does this affect? Who is at the highest risk for undergoing these procedures? The research indicates that girls ages 6 through 12 are at the highest risk, but it's also important for us to consider newborn girls, girls approaching menarche, and girls approaching marriage, as these are all vulnerable times in their lives as well. Then there are female immigrants, refugees, and asylees from prominently affected countries. And while these practices are not exclusive to any one area of the world, it is worth noting that 1/4 of all FGM or C cases are found in the Middle East and North Africa. While the origin of female genital cutting and mutilation is mostly unknown, we do know that it precedes Abrahamic religions and is thought to have existed in ancient Egypt, Ethiopia, and Greece. We know that it transcends religion, geography, and socioeconomic status. However, a small number of Muslims have adopted the practice as a religious requirement, as I mentioned previously. Up until the 1960s, American obstetricians performed clitoridectomies to treat erotomania, lesbianism, hysteria, and clitoral enlargement. And in the past 30 plus years, grassroots national and international organizations have made large strides in eradicating the practice through promoting awareness and education. And through these efforts, today the practice is recognized as a violation of human and child rights in most areas of the world. As of 2016, the World Health Organization reports that more than 200 million women currently alive have been subjected to female genital mutilation or cutting worldwide, and 3 million girls continue to be at risk each year. 24 countries in which FGM or C has historically been concentrated have enacted legislation against the practice. However, in some areas, the practice has decreased, while in others, it has increased or stayed the same. Also, the CDC estimates that as many as 513,000 women and girls in the United States could have experienced FGM or C or are at risk of experiencing it in the future. This is a map indicating the percentage of females aged 15 to 49 with FGM or C. You'll notice that Guinea and Somalia, found in the northern region of Africa, uphold the highest rates. And in Somalia, the practice actually affects up to 98% of women and girls. Here are some awareness, treatment, and prevention approaches that can be used by both healthcare professionals and the general public when it comes to combating this issue. At the top, we have health risks and complications because, as previously mentioned, this can be a very harmful traditional practice, and it does pose a threat to the health of women and girls across the globe. Underneath that is the legal and human rights approach, establishing an intergenerational dialogue, promoting girls' education and empowerment to oppose FGM or C, support for girls escaping from early marriage and FGM or C, the alternative rites of passage, and of important note there at the bottom is that eradication should be a collective effort by civil society and government. There are a number of awareness, treatment, and prevention programs in existence. First of all, we have the CDC, which provides estimates and documentation of cases in the United States. There's also international human rights treaties, which address the impact of FGM in hampering gender equality and provide guidance about appropriate responses to FGM or C by healthcare providers. According to one source, few pre or in-service training programs for healthcare providers address how to recognize and treat FGM, and there are fewer tools and programs to provide healthcare to women who have undergone FGM compared with those that prevent it from ever occurring. Health providers are often reluctant to address the topic because they may feel they have no role in addressing cultural practices. There's also the WHO 2016 guidelines, which is a resource for healthcare providers that covers what counseling and care should be provided, what to do if they suspect a girl is at risk, how to handle requests by a woman or family members to re-infibulate a woman after delivery, and whether or not it is the role of the healthcare provider to counsel families against the practice. In addition, I've provided several other resources that are appropriate for both healthcare providers and clients. Now, what can we as nurses do about this? What is our role in the grand scheme of things? Number one, we can identify children at risk and build trusting relationships to treat children affected by this practice. Number two, we can develop interagency guidelines to provide safe processes for the child and the family. Number three, we can promote awareness and address knowledge gaps about FGM/C among other healthcare professionals, clients, and the public. We can work using a multidisciplinary approach for effective prevention. And we can collaborate with urologists, gynecologists, sexologists, and pediatricians to combat this issue. All right, so this concludes my presentation about this topic. I realize that was a lot of information, but I hope you took away at least a little something. I thank you for watching and for listening.